Thanks, Doug. So, I will be talking about the new covered destinations as outlined by Medicare through CMS HHS. And what they did was implement a new interim final rule in the very beginning of April. A new section was added under provision F5. What that provision did was to say that all destinations that are equipped to treat the condition of the patient consistent with EMS protocols established by state and or local laws where the service will be furnished will now be considered a covered destination. So what we really have here is kind of a two-pronged test that we have to look at. So first we look at whether this destination location is equipped to treat the patient, but then also looking at, can this be a place that under local and state protocols are we even allowed to transport a patient there? So some of these alternate destinations can include, now keep in mind when I say alternative destinations or alternate destinations, it's important not to confuse that with the way this alternative destination was used with the ET3 model. This is completely unrelated to ET3. Any location that is an alternative site that's determined to be part of a hospital, critical access hospital, or skilled nursing facility. So as we know, a hospital, a critical access hospital, or a skilled nursing facility, they're already covered destinations. But what this is saying is that it's some location that's kind of an alternative site. So the easiest example maybe is in an emergency situation, ambulance transports a patient to the ED of the hospital. They roll up to the bay, they unload the patient. That is where they normally transport the patients and take them to at that hospital. So there might be in this COVID pandemic alternative sites on the hospital campus, at the hospital building that an ambulance service might not be used to transporting a patient to. They might be told to take them around the back, use a certain entrance. This is where we're taking COVID patients. This is where we're taking non-COVID patients. Do not be using the ED bay that we normally use, but use this location instead. Maybe it's even an ancillary building that certain patients have to be transported to. So those are the types of locations at a hospital complex as an alternative site where patients are specifically being told to be brought to. Another list then of these new covered destination locations as defined by Medicare include mental health centers and different types of clinics, rural health clinics, even urgent care centers and clinics and facilities, physicians' offices, ambulatory surgery centers. Now, just hearing the names of these types of things, they're what were typically non-covered destinations. They're sounding like our, obviously, P's for physicians' offices, types of D's, diagnostic and therapeutic type centers, as we've classified things like urgent care centers and ambulatory surgery centers that are, freestanding, not affiliated with a hospital. These are the types of places where CMS has now said, yes, if you are bringing a patient here to receive certain services, these types of things can now be covered. A little bit more about that shortly. Another new covered destination, and the way Medicare has kind of described things a little bit differently, deals with ESRD and patients who require and receive dialysis. So the first thing to remember, of course, we have two existing modifiers that deal with dialysis. Your G for hospital-based and your J for non-hospital-based. Those still exist and those still can be used for patients who are receiving dialysis services. What Medicare has done is said, yes, if there is the situation where a patient is now going somewhere else to receive dialysis services, they've got the dialysis equipment, but it's not an existing hospital-based dialysis center. It's not an existing freestanding dialysis center, but it is some location that is temporarily being used to dialyze patients. That now is going to be a covered destination. We'll talk more about exactly what modifier that uses in a few minutes. The other, quote, new covered destination deals with the beneficiary's home. Now, we all know that when we take a patient home to their residence, we use the R. The way this has gotten a little bit interesting in this situation is that historically, if we took a patient from their residence to a physician's office, that would be non-covered because a P was historically not a covered destination. If we then take that patient from the physician's office back to their residence, that also would not be covered. So what Medicare has done here has said that yes, a transport to the patient's residence when they are coming from some otherwise non-covered or previously non-covered destination, such as a physician's office, that now can be covered. So a big question we've seen is, do these alternative destinations apply only to the COVID-19 patients? The answer is no. For these alternate destinations and these new covered destinations, they are going to apply to any Medicare beneficiary during this entire extent of this public health emergency. Of course, we don't know when it's going to be declared over as of yet. So as long as the PHE is still in place, these new covered destinations will apply, whether it is a suspected COVID patient, whether it is a confirmed COVID patient, or whether it is not a COVID patient at all. This is relevant because in certain healthcare situations, hospitals in particular are directing non-COVID patients to go to certain places, whereas COVID patients are being told to go to other places just to kind of keep some degree of isolation. So of course, if the hospital is instructing EMTs and medics to transport non-COVID patients to a particular location, then of course non-COVID patients are being affected by this as well, because then now they're being told to go to some other location, and maybe it's going to be one of these alternative destinations. And this is why then this is something that does have to affect both COVID patients and your non-COVID patients, depending on just the way local hospitals and other receiving locations have classified where patients are supposed to be going. Several slides ago, I had mentioned that it's basically a two-pronged approach, in that we've got CMS rules that talk about, yes, there can be alternative destinations for Medicare billing purposes, but of course, we still have to meet state and local EMS protocols. So if we are not satisfying those state and local EMS protocols, then we can't rise to the level of billing Medicare, because we always have to meet our state and local requirements in addition to our Medicare requirements. So for example, some state EMS regs will specify which are going to be appropriate locations and destination locations for EMS practitioners, your EMTs and your medics, to ultimately transport a patient. Sometimes there's nothing like that. Sometimes it does delineate, that these are the types of places that a patient can be brought to. Maybe, for example, you're not allowed to transport a patient to a physician's office. You're not allowed to transport a patient to a freestanding clinic of some sort or an urgent care center. There might be state or local protocols that specifically forbid that from happening. So just because Medicare has relaxed its standards for Medicare billing purposes does not mean that you can ignore any state requirements. So you might have to get in touch with the people at the state or in a more regional or localized area, that if there are any specific things in place that would restrict where you are able to transport patients, to get those things at the state or local level relaxed as well. Because again, you need to have both pieces of it, the state and local piece allowing you to transport a patient there, and the Medicare piece allowing for that transport to that location to now be ultimately billed to the Medicare program as an alternative destination. So it will vary. Sometimes it's a local EMS agency, sometimes it's regional, sometimes it's a state council, sometimes it's a regional council, sometimes you might have to have a state waiver, maybe the Department of Health or the Department of Public Welfare is involved. There might have to be a temporary protocol, it might have to be a rule, who knows? In some cases it might be by law and it might need to ultimately be changed by the lawmakers as opposed to something on a lower protocol or regulatory level. And this is somewhat tricky because, we always teach that federal law trumps state law, and there are times that, state law can be more stringent than federal law, and that you've got to follow the different things. So, of course, in this case, we're talking about Medicare and what is going to be acceptable for Medicare billing purposes. Again, we might have an issue of a state law being a little bit more stringent. So just because Medicare might say, yes, we are willing to pay for some transport to some alternate destination, does not mean that you meet all of the underlying criteria, be it even Medicare coverage criteria, medical necessity and reasonableness. It doesn't do anything else to relax PCS requirements and signature requirements and anything else like that. So you still have to meet all the other Medicare coverage criteria, but you also need to make sure you meet the EMS system protocols. So you can't say, oh, well, Medicare said this is a covered destination, so just because Medicare said it's covered, that must mean it's covered by the state as well. It's not the case. You need to make sure that things are going to be relaxed as necessary by your state. Key thing to remember too, if you're a billing company dealing with multiple states, it's going to apply to all of those states. You need to be familiar then with how these covered destinations match up, state to state, region to region, locality to locality. It is critical to also remember that Medicare is not covering any kind of treat no transport or treatment in place. That is not what has been done here with these expanded list and scope of the covered destinations. Nothing has been changed to now suddenly allow for treatment that occurs within the patient's home or other origin point to now be covered. There must still be a transport. However, that is Medicare. For other payers, commercial insurances, certain Medicaid programs, those other payers might cover a treat no transport. So you need to know what those different payers are doing and what they are going to cover, and then how to bill for it, because we've seen and heard different payers using different codes, either the AO998 or the AO999. Perhaps it's the unlisted ambulance service, or perhaps it's couched as the treat no transport. So you've got to check with your payers, your commercial payers, to see how they want this treat no transport to be billed, if it can be billed at all. And if it can't be billed, if you're a Medicare patient, not a covered Medicare service, there's nothing that says you can't bill the patient directly. This is a Medicare non-covered service. For that, where do you go next? You can bill the patient. Remember also, this is not the ET3 program. Changing anything with these covered destinations and adding some new covered destinations, this does nothing to change anything about ET3. In fact, this has nothing to do with ET3. In fact, ET3 has been delayed. It was supposed to start in the spring or summer, and now it's been delayed until the fall. So when I mention alternative destinations, I am not talking about alternative destinations in the context of ET3. I am talking about alternate destinations in the context of the COVID public health emergency and the revised, likely temporary addition to the regulation that allows for transports to certain additional list of covered locations and destinations. So of course, when we talk about destinations, first thing that comes to mind is, what modifier do we use? So with this expanded list of new covered destinations comes some guidance from Medicare to tell us what is the most appropriate modifier to use for these different types of destinations. The first modifier to talk about is D, and this is actually where most of the expanded list of alternative destinations will really fall. This is where our health centers, our health clinics, our urgent care facilities, this is where this would all go. Now, historically, these types of places, probably what we would classify these types of places, but of course, a D was not a covered destination, perhaps in certain exceptions, which we don't need to get into here. But historically, if you were taking a patient to any of these locations, this was not covered. Now there is this temporary authorization under Medicare that says this transport to these types of locations can be billed to the Medicare program, again, as long as state and local protocols are satisfied. The one interesting thing to note there at the bottom is that when we're talking a non-provider, non-hospital-based ambulatory surgical center or non-hospital-based emergency department, that's when you would use the D. If it is provider-based or hospital-based ED or ambulatory surgical center, then we are going to still use the H as we would have normally. Also fitting into the modifier D category is any location other than your typical G, hospital-based dialysis, or J, freestanding dialysis, where you're taking the patient to some place for the patient to get dialysis services. If we have some facility that a health department, that a hospital, that a dialysis clinic, whatever, has set up as a new location, this is where we are going to bring some of our patients. Perhaps they're using the existing dialysis center as a location for COVID patients, and they've set up another location where we are going to dialyze the patients who are non-COVID to keep some degree of separation. So we are not going to our typical dialysis center, but we've got some equipment that we've placed here in some other location. This is now going to be that D. And again, this is going to be an allowed covered destination. Transport a patient to some special location to receive a service, in this case dialysis, that's just being provided in some place other than your typical dialysis location. Moving on then to the E modifier. The only thing that's been modified a little bit here is the last piece of this. Because our classic definition of the E modifier is residential, domiciliary, or custodial facility other than a Section 1819 facility. So one thing that's been added is if the facility is the beneficiary's home. So what this really seems to mean is these patients are long-term care patients. This is where they are being cared for. This is where they essentially live. Whether it be assisted living, personal care, patients with some degree of mental health problems. This is basically their home. Now, contrast this with a private residence, a condo, an apartment, where that's where we're going to still use our R for our residence. What we're talking about with this E is that, yes, you can have patients that live in some residential custodial type facility that you're ultimately bringing them back to after they've received some degree of medical care somewhere, even if it might just be going somewhere for a test to see if they are COVID positive or not, to see based on their symptoms whether they can be quarantined at their home, be it even this residential domiciliary type custodial facility. The next one is our H modifier. And as I said before, this doesn't change anything with our existing hospitals, our critical access hospitals. Those are still covered destinations. What we're talking about, though, is when we've got some alternative care site that's still under the license and under the auspice, in a sense, of the hospital. If there are naval hospital ships that have been stationed out there at off the coast of New York and LA for additional overflow help of non-COVID patients, certain provider-based freestanding EDs that have been designated as this is where you're supposed to bring COVID patients or where you're supposed to bring non-COVID patients. So it's just expanding it, anything that might pop up. Heck, maybe there's some little used building on a hospital campus that now has become a hot site for people to be transported to for whatever the case may be. Maybe it's become for x-rays or MRIs. Maybe it's for COVID testing. Whatever is going on, they've got a new alternative place for people to receive care that has had to become necessary because of this public health emergency. Modifier N, and again, like the H, this is where we've got alternative care site for a skilled nursing facility. Of course, skilled nursing facility was a covered destination, remains to be a covered destination. This is where we might have some kind of waiver being requested by a SNF from CMS to say, hey, we've got some off-campus location. We would like to be able to move some of our patients to a hotel down the street because we've got a big number of COVID positive patients. We're treating them here in our SNF, but we've got some non-COVID patients that can be treated. They're lower acuity. We can put them into this hotel. We can treat this hotel almost like a SNF. This is where we're putting our non-COVID patients to provide them care. This is some kind of satellite of the SNF. We're kind of using it as, falling under our license that we already have in place. So that could still meet the N modifier. It's an alternative care site. So this is why you then need to know more from this SNF. What have you done with your license? What's covered? What's not covered? Do you have ancillary and satellite coverage areas? Do you have some waiver from CMS? What is going on here? This is why it becomes so important to ask questions of your healthcare partners to figure out exactly what's going on, where these patients are going, and whether you then satisfy all of the criteria from both Medicare perspective and the perspective of your state and local protocols. Regarding the modifier P then, this is the physician's office. Same definition, same kind of code or modifier that we've always used. This, as we know, was only a covered destination in some intermediate stop en route to a facility. Very rarely, if ever, it was used. This is when you were supposed to use the X modifier that I can honestly say I've never seen that kind of thing be used. But what Medicare has said is that this can be a covered destination during this public health emergency if it's going to be permitted by the state and local protocol, and where it's medically necessary, and where that transport to the physician's office is going to be something that has become important and necessary to treat the patient's condition. Finally, this modifier R, this is the beneficiary's home. And again, they've used this word home where historically they've used the word residence. So this is interesting. It's always been a covered destination when we're talking about a discharge from a hospital. But now this really can become a covered destination from any point of origin. Now, naturally, we still need to meet medical necessity, and there's always going to be that underarching problem. There's always going to be that underarching question of why this patient needs an ambulance to maybe go from a physician's office back to a residence, be it for self-quarantine or whatever the case may be. But medical necessity still must be met. Just because now Medicare has said a P to R transport can be covered, that does not do anything to eliminate all other coverage criteria. So again, thanks to our webinar sponsor, QuickMed Claims. That said, I'm going to kick it over to Chris Kelly.